Hello everyone. The next developmental disturbances affecting oral and paraoral structure that is discussed today, that is developmental disturbances affecting the structure of teeth. First is amelogenesis imperfecta. Amelogenesis imperfecta is also known as hereditary enamel dysplasia, hereditary brown enamel, hereditary brown opalescent teeth. A complex inheritance pattern gives rise to amelogenesis imperfecta, a structural defect of the tooth enamel. The formation of enamel is a multi-step process and problems may arise in any one of the steps. In general, the development of enamel can be divided into three different major stages. First is elaboration of the organic matrix. Second one, that is mineralization of the matrix. Third is maturation of the enamel. The hereditary defects of the formation of enamel also divided into hypoplastic type, hypocalcified and hypomaturation type of amelogenesis imperfecta. Molecular genetic studies have shown that the etiology of amelogenesis imperfecta is related to the alteration of genes involved in the process of formation and maturation of the enamel. Although the genetic origin of the autosomal forms is less understood, analysis of X-linked amelogenesis imperfecta has shown the defective gene for this specific amelogenesis imperfecta closely linked to the locus DXS85 at XP22. This also has been identified as the general location of the human gene for amelogenin, which is the principal protein in the developing enamel. Then coming to classification of amelogenesis imperfecta. This classification according to Whitaker in 1989. First is type 1, which is hypoplastic variant. In type 1, again it is classified into 1A, that is hypoplastic pitted autosomal dominant. Type 1B, which is hypoplastic local autosomal dominant. Type 1C, that is hypoplastic local autosomal recessive. Type 1D, which is hypoplastic smooth autosomal dominant. Type 1E, hypoplastic smooth X-linked dominant. Type 1F is hypoplastic rough autosomal dominant. Type 1G, which is enamel agenesis, which is autosomal recessive. Next type is type 2, which is hypomaturation type of amelogenesis imperfecta. Type 2A is hypomaturation pigmented autosomal recessive. Type 2B, hypomaturation X-linked recessive. Type 2C, snow-capped teeth autosomal dominant. Type 3 is hypocalcified type of amelogenesis imperfecta. Type 3A is hypocalcified autosomal dominant. Type 3B is hypocalcified autosomal recessive. Next is type 4 of amelogenesis imperfecta, which is hypomaturation hypoplastic with taurodontism. Type 4A is hypomaturation hypoplastic with taurodontism autosomal dominant. Type 4B is hypoplastic hypomaturation with taurodontism autosomal dominant. First type is hypoplastic amelogenesis imperfecta. In hypoplastic amelogenesis imperfecta, the basic alteration centers on inadequate deposition of enamel matrix. Any matrix present is mineralized appropriately and radiographically contrasts well with the underlying dentine. In the generalized pattern, pinpoint to pinhead sized pits are scattered across the surface of the teeth and do not correlate with a pattern of environmental damage. In the clinical picture, the first picture you see, this is a hypoplastic amelogenesis imperfecta, which is generalized pitted pattern. There are numerous pinpoint pits which are scattered across the surface of the teeth The enamel between the pits is of normal thickness, hardness and coloration. In the right side, the second picture is the same patient. There is diffuse involvement of all the maxillary teeth, which is inconsistent with environmental damage. Then is the localized pattern. The affected teeth demonstrate horizontal rows of pits, a linear depression or one large area of hypoplastic enamel surrounded by a zone of hypocalcification. Typically, the altered area is located in the middle third of the buccal surfaces of the teeth. The incisal edge or occlusal surface usually is not affected. Both dentitions, only the primary teeth may be affected. All the teeth may be altered or only scattered teeth may be affected. When the involvement is not diffuse, the pattern of affected teeth doesn't correlate at a specific time in the development. The autosomal recessive type is more severe and typically demonstrates involvement of all teeth in both deciduous and permanent dentitions. Then is autosomal dominant smooth pattern. The enamel of all teeth exhibits a smooth surface and the enamel is thin, hard and glossy. The absence of appropriate enamel thickness results in teeth that are shaped like crown preparations and demonstrate open contact points. The color of the teeth varies from opaque white to translucent brown. Radiographically, the teeth exhibit a thin peripheral outline of radio-opaque enamel, often unerupted teeth exhibiting resorption. So first is the clinical picture of hypoplastic amelogenesis imperfecta, autosomal dominant smooth pattern. In the clinical picture, small yellowish teeth exhibit hard glossy enamel with numerous open contact points and anterior open white. In the radiograph picture of the same patient exhibit thin peripheral outline of radio-opaque enamel. Then X-linked dominant smooth pattern. On approximately the 16th day of embryonic life, in all the individuals with two X chromosomes, one member of the pair is inactivated in each cell. As a result of this event, females are mosaics with a mixture of cells, some with active maternal X chromosomes and others with active paternal X chromosomes. So there is usually the mixture is of approximately equal proportions. If one X chromosome were to direct the formation of defective enamel and the other X chromosome were to form normal enamel, the teeth would exhibit alternating zones of normal and abnormal enamel. So there are males different clinical features, females showing different clinical features. Males with the X-linked dominant smooth pattern exhibit diffuse, thin, smooth and shiny enamel in both primary and permanent dentitions. The teeth often have the shape of crown preparation and the contact points are seen. The color varies from brown to yellow-brown in color. Radiograph, they demonstrate a peripheral outline of radio-opaque enamel and unerupted teeth may undergo resorption. On the other hand, females exhibit vertical furrows of thin hypoplastic enamel alternating between bands of normal thickness. The banding is often detectable with dental radiographs. Then coming to rough pattern of amelogenesis imperfecta. The enamel is thin, hard and rough surfaced. As in the smooth forms, the teeth taper towards the incisal occlusal surface and they demonstrate open contact points. Here, the enamel is denser than that seen in smooth patterns. The teeth are less vulnerable to attrition. In the clinical picture, you see small yellow teeth with rough enamel surface and open contact points, significant adhesion and anterior open bite. In the radiograph, they exhibit a thin peripheral outline of radiodense enamel. Next is amelogenesis. It demonstrates a total lack of enamel formation. The teeth are the shape and color of the dentine with a yellow-brown hue, and there is open contact point and the crown taper towards the incisal and occlusal surface. The surface of the dentine is rough and there is an anterior open bite is seen frequently. Radiographs that demonstrate no peripheral enamel overlying the dentine, and there is a lack of eruption of many teeth with significant resorption. Next is type 2, which is hypermaturation amelogenesis imperfecta. In a person with hypermaturation amelogenesis imperfecta, the enamel matrix is laid down appropriately and begins to mineralize. However, there is a defect in the maturation of the enamel's crystal structure. Affected teeth are normal in shape but exhibit a mottled, opaque, white, brown, yellow discoloration. The enamel is softer than the normal and tends to chip from the underlying dentine. Radiographically, the affected enamel exhibit a radiodensity that is similar to dentine. The next pattern is pigmented pattern in hypermaturation type. The surface of enamel is mottled and agar brown. The enamel often fractures from the underlying dentine and it is so soft enough to be punctured by a dental explorer. Occasionally, the surface enamel may be affected severely and be similar in softness to that of hypocalcified patterns. These cases often demonstrate extensive calculus deposition. Next is X-linked pattern. Affected males exhibit different patterns in the deciduous and permanent dentitions. The deciduous teeth are opaque white with a translucent mottling. The permanent teeth are opaque yellow-white and may darken with age. The enamel tends to chip and often be pierced with a dental explorer point, and the degree of enamel loss is more rapid here than that is seen in the normal teeth. Focal areas of brown discoloration may develop within the white opaque enamel. This is a clinical picture of X-linked pattern. Here the dentition exhibiting mottled opaque white enamel with scattered areas of brown discoloration. Radiographically, the contrast between enamel and dentine is reduced. Female patients exhibit a similar pattern in both dentitions. The teeth demonstrate vertical bands of white opaque enamel and normal translucent enamel. The bands are random and asymmetric. The banding is not obvious under regular lighting and transillumination often required to demonstrate the pattern. Radiographically, the band is not perceptible and the contrast between enamel and dentine is within the normal limits. Then is snow cap pattern. It exhibits a zone of white opaque enamel on the incisal or occlusal 1/4 to 1/3 of the crown. In the picture you see the incisal third and the occlusal 1/3 is totally like opaque white in color. The affected teeth, they shows anterior to posterior distribution and denture dipped in white paint. It appears like denture dipped in white paint. Here both the dentition, that is primary and permanent teeth, are affected, and most cases demonstrate an X-linked pattern of inheritance, but there possibly is an autosomal dominant form also. Next is hypocalcified amelogenesis imperfecta, which is type 3. In this type, the enamel matrix is laid down appropriately, but no significant mineralization occurs. In both patterns of hypocalcified amelogenesis imperfecta, the teeth are appropriately shaped on eruption, but the enamel is very soft and easily lost. On eruption, the enamel is yellow-brown or orange in color, but it often becomes stained brown to black, and it exhibits rapid calculous apposition. In the clinical picture, you see the dentition exhibiting diffuse yellow to brown discoloration and numerous teeth with loss of coronal enamel except for the cervical portion is affected. In the radiograph of the same patient, there is extensive loss of coronal enamel and the similar density of enamel and dentine. Next is hypomaturation hypoplastic amelogenesis imperfecta. This type of amelogenesis imperfecta exhibits enamel hypoplasia in combination with hypomaturation. Both the deciduous and permanent dentitions are involved diffusely. Two patterns are recognized that are similar but differentiated by the thickness of the enamel and the overall tooth size. In the hypomaturation hypoplastic pattern, the predominant defect is one of enamel hypomaturation, in which the enamel appears as mottled, yellowish white to yellowish brown. Peats are frequently seen on the buccal surfaces of the teeth. Radiographically, the enamel appears similar to dentine in density, and there is large pulp chambers may be seen in single rooted teeth, in addition to various degree of taurodontism. In the hypoplastic hypomaturation type, the predominant defect is one of the enamel hypoplasia, in which the enamel is thin and the enamel that is present that demonstrates hypomaturation except for the decrease in the thickness of the enamel. This pattern is radiographically similar to the hypomaturation hypoplastic variant. Both the patterns they are seen in the systemic disorder that is known as trichodento-osseous syndrome. This autosomal dominant syndrome is mentioned here because the diagnosis may not be readily apparent without a high index of suspicion. This is a picture of trichodento-osseous syndrome. Here the dentition exhibiting diffuse enamel hypoplasia and hypomaturation. At birth, the patient exhibits a kinky steel wool texture to her hair. With time, the hair straightened. A high index of suspicion was required to arrive at the diagnosis. In the radiograph of the same patient, you see there is a significant taurodontism of the first molar and the enamel which is very thin and similar in density to the dentine. Then coming to histopathological features, the histopathological alterations present in amelogenesis imperfecta are not evident in routine preparation. Because decalcification of the teeth is necessary before processing to allow sectioning of paraffin embedded specimens, in that decalcification section all the enamel is lost. To examine the enamel structure of altered teeth, ground sections of non-decalcified specimens are prepared. Then treatment. The clinical implications of amelogenesis imperfecta vary according to the subtype and its severity. But the main problems are the aesthetics, dental sensitivity, and loss of vertical dimension. If there is very thin enamel or highly defective enamel, which leads to rapid attrition, these variations require full coverage as soon as possible. If the treatment is delayed, a loss of usable crown length occurs. In those patients without sufficient crown length, there is full denture is advised, and sometimes overdentures is also advised. The other types of amelogenesis imperfecta demonstrate less rapid tooth loss and the aesthetic appearance is a prime consideration. In some cases, a lack of good enamel bonding of veneers occur and doesn't result in a durable restoration. So these are all about amelogenesis imperfecta, that is affecting the structure of a tooth. So I hope you like this video. Thank you so much.